Grading, normally we have international standards for grading, which is the W.H.O standard. And WHO since 2004 has not changed. It's always low-grade and high-grade tumors. And of course, everybody is aware that there are tumors which are mixed tumors. So you have, for example, 70% of low-grade and 30% of high-grade. But once again, the WHO is very, very clear about this. They say, well, if you have more than 5% of high-grade, this should be considered as a high-grade tumor. And I think this is pretty easy to sort it out even if you're a pathologist. Nevertheless, the EAU guidelines, they recommend another system based on research which they have driven, but it's not pathology research, it's urology research. And it's a big mess now in Europe because many people use, of course, WHO according to the international standards. Others want us to use an old classification, which is from 1973. They want us to make a kind of hybrid system between both systems. And we have recently written a paper in histopathology where every pathologist more or less explains why he prefers this or that system. I really believe, and that's a very personal thing, that a classification is supposed to be used by everybody. What the EAU wants is something like we have a highly sophisticated uropathologist, dedicated uropathologist who does just uropathology. And of course, he or she will be able to do both systems. But very many people do everything. So it is really important that we have a system which can easily be applied by everybody, by every pathologist who does pathology. And I think low-grade, high-grade is very good. The second thing, and I really believe in this too, is, I mean, these discussions will not lead very far because the real problem will be probably with artificial intelligence, something like this. Artificial intelligence will maybe help us and to sort it out. And there are already several systems which show you high-grade, muscle-invasive, high-grade, non-muscle invasive, low-grade, non-muscle invasive tumors with this kind of heat maps, and they do a very good job now. So I really believe that on the long term, it will be maybe artificial intelligence which will help us to find the cutoffs from when on a tumor is really high-grade and from when on you still can treat the patient as a low-grade tumor, which is pretty important for the patient, of course.